Welcome back everyone. It's my honor to call upon esteemed Professor Dr. Kalpana ma'am, Barnard Institute of Radiology on stage for her presentation on the topic Interventional Radiology. She has won award from Tamil Nadu government for outstanding contribution. She has contributed tremendously towards the development of Department of Intervention Radiology and also started DM Intervention Radiology at Madras Medical College. She has conducted conferences, has been scientific committee chairperson and has delivered guest lectures in state and national conferences. We welcome you, ma'am.
Thank you. A very good morning to you all. I am pleased to be invited to KARE to present on a topic which is close to my heart, interventional radiology. Can I have a hands up of how many people have do interventions in your department, wherever you're posted? Okay. I can see there are quite a few number of hands. So I just try to cover some basic interventions which you may be asked for in exams, and I hope it is useful to you. So this is an image, an ultrasound image. So the common questions will be, what is the method of image guidance used, and if multiple biopsies are required, what type of biopsy procedure would you prefer? What are the common types of biopsy guns? And what is the measuring parameter for biopsy guns? How do we measure them? And if you would want to do a venous route for biopsy, in what condition? 1 minute. Okay, I'll just go through the answers. So what is the method of image guidance used? It is the longitudinal or transverse guidance by ultrasound probe. You can use, if multiple biopsies are required, you necessarily have to have a coaxial biopsy procedure where the coaxial gun is kept into the lesion and you can take repeated biopsies. The common type of biopsy guns are semi-automatic and fully automatic, and the measuring parameter is the gauge. Normally we use 16 to 18 gauges, and we prefer the venous route for biopsy in transjugular liver biopsy over the percutaneous route when there is ascites or uncorrectable coagulopathy, where if you take a percutaneous route through the skin or the intercostal region, there will be bleeding and there will be no tamponade because of the ascites. So in a transvenous biopsy, even if the bleeding occurs, it occurs into the IVC, and so it is intravascular, and so there are less complications. The type of biopsy guns, as I said, are semi-automatic and fully automatic. The diameter of the needle is in gauge. It usually varies from 14 to 20 gauge, 14 being the largest and 20 being the smallest. So 14 is the normally one which is prescribed for mammogram biopsies, because we need also the histopathology of those lesions. And they are normally used for soft tissue lesions, while for bone you have the bone biopsy guns, which are a separate category. And you need a coaxial system, especially if the lesion is deep in the pancreas, or when you need a coaxial system. While in the breast you may not need a coaxial system because it is a very superficial lesion, then you may not require a coaxial system, and the tract is made when you put the first biopsy gun, and you can follow the same tract without a coaxial system. So the approach to the lesion is either the long axis or the in-plane method, where the needle is inserted by the side of the probe. So the advantage is we see the whole needle route through the ultrasound or through the image. So you can find out where the needle is going, where it is pointed, and you can change the route. The good needle visualization is a characteristic of the longitudinal or the long axis upward, and the entire needle trajectory will be seen. While in the short axis, where you put it in the center of the probe, you can only see a part, or the probe, the needle tip is seen as a dot. So you do not know whether you're seeing the tip of the needle or the middle of the needle. And so you have to move the probe up and down to identify where your needle tip is. So, but this is also useful in smaller superficial lesions, but the preferred is the longitudinal, where you can see the whole needle in the image. So that is a better method. So this is a short axis. It shows the needle only in the cross section. The entire length is not seen, and difficult to identify the tip. Now this is a 40-year-old male with fever and right intercostal tenderness. Here is an ultrasound image. So the diagnosis is obvious. How would you manage this patient? What would you like to do? And when would you consider your management was successful? Or when can you stop your interventional procedure? And what is the technique used for hydatid cysts? So these are all related to the diagnosis, which is obviously a liver abscess, which is also seen on CT with enhancing periphery. And the preferred interventional management is percutaneous pigtail drainage of the abscess, where through the intercostal space you put a pigtail, usually a 12F, because a 12F is a 12 French, which is a larger diameter catheter, so that the necrotic contents and the pus can come out. So 12 to 14F is or even 16 if it is a very thick pus, then you may need. While a 6F, 5F catheters are for clear fluids like for urine or ascites, then you can put a 6F or a 5F catheters or a 7F. But you need 12, 14, 16 and higher if there is a thick necrotic material for any drainage in the body. So when do you consider your management was successful? When the drainage drops to 10 to 30 ml, provided there is no block in the catheter, and you have to assess it by a repeated ultrasound or CT, where you can see the size of the abscess has collapsed and the drainage is dropped to less than 10 ml, then you can remove the catheter. So what is the technique used for hydatid cysts? It is called KARE, which is puncture, aspiration and injection, where we inject hypertonic saline into the hydatid cyst, which is a scolicidal agent, and you can kill the hydatid scoliosis. This is a 45-year-old male with chronic pancreatitis, severe abdominal pain, and this is the CT image. So now what is the procedure which is depicted? What is probably injected? Where else can we use this technique, and name any 2 complications of this procedure. So now this is a CT image you can see, and you can see that there are 2 needles placed via the anterior abdominal wall, and you can see it is directed towards the aorta, and this is the celiac artery. So both the needles are in the fat plane around the celiac artery, so it is a celiac plexus neurolysis. And what is injected commonly, it is a long-acting anesthetic and alcohol. Both are injected through this. In this patient, we initially inject contrast so that we are sure that this contrast is not entering this, whatever we inject is not going into the vessels or the celiac, and we can find the plane of injection. If it is difficult to put 2 needles, we can put 1 needle, inject the contrast, see if it is spread bilaterally, then you don't need to put 2 needles on either side of the celiac axis. So this contrast is just to see where the injection of your chemicals will go. So this is a local anesthetic, which is usually a long-acting local anesthetic like bupivacaine, and because it gives immediate relief of the pain, and a neurolytic which will cause destruction of the Schwann cells of the nerve fibers, so that there is more permanent relief of pain. So this is usually done in chronic pancreatitis, severe pain, which is immune to normal anti-inflammatory analgesics, and also in pancreatic cancer when the celiac plexus is invaded and there is pain which cannot be easily relieved. So we can also use this technique in hypogastric plexus, or so that in lower limb when there is ischemic pain or rest pain, then to relieve the pain we can also use this technique elsewhere. So the main problem with the celiac plexus neurolysis is postural hypotension and diarrhea, because we are occluding the sympathetic nervous system, and so the patient has a loss of the normal reflexes and diarrhea because the bowel loses its peristaltic activity. Now this is an image of a Gravida 2 para 1 alive 0 with a female patient with a previous anomalous fetus. So this gives you a clue about what this procedure is done. So what gestational age is this procedure done? So we assume that you already know what is the procedure, and in early gestation what other procedure can be done for the diagnosis, and high risk in which common prenatal test leads to a request for this procedure, and what form is mandatory before you do this procedure. So it is, if you can pick it up, this is a placenta, this is amniotic fluid, and this is the needle and the needle tract through the placenta. This is the needle tract. So what are we doing? The procedure is amniotic fluid aspiration or amniocentesis, and the gestational age, this is preferred as 17 to 20 weeks, preferably for anomaly detection, but we can also do it in term fetus when there is hydramnios and you want to relieve the amount of amniotic fluid aspiration. Otherwise, for diagnostic, you do it only after 16 weeks because the amount of fluid there needed for aspiration will be there only after 16 weeks. So if you want to do the diagnosis before the 16 weeks, the chorionic villus sampling. So in early gestation, what other procedure can be done? Chorionic villus sampling can be done in 11 to 14 weeks. And which common prenatal test says it's a high risk for Downs? Triple test is a high risk for Downs. Then we can do this amniotic fluid amniocentesis for diagnosis. So the serum markers which are used in the triple test are alpha fetoprotein, unconjugated estriol, and HCG. So which form is mandatory according to PNDT Act? We have to fill up the form F and get it signed by the patient and the doctor. Now this is a male 21 years with severe pain in the right knee or the leg, and which is relieved by aspirin. The history is very indicative that of the diagnosis. This relieved by aspirin and night pain is a very indicative diagnosis. So what is the finding on X-ray and how do you manage the lesion? Name the 3 other organs where this procedure can be done. Whatever you decide to manage for this patient, what other organs can you use the same procedure, and what is the common age group of this lesion? So you can see there is a sclerotic lesion in the diaphysis of the tibia, and on PET CT it is taking up the radionuclide scan. So it is a sclerotic lesion with nidus, which is well seen on CT, and there is cortical thickening. There is uptake on PET scan, which is only occasional. It is not always there, and only some lesions will take up. So what is the management? We can do a percutaneous thermal ablation by RFA or laser. Both can be used. So how do we do it? We need to enter the cortex and the nidus using the bone biopsy gun, and once you reach the nidus, you put the RFA probe through it or the laser antenna through it and burn the nidus, which is actually a vessels. It's only a vascular nidus. And you can also use this RFA procedure in other organs like the liver, thyroid, and renal tissue. It is usually common in the 4 to 24 year age group. The osteoblastoma, I'm sorry, I didn't mention, this is the osteoblastoma, and it is common in the 4 to 24 year age group. Now, percutaneous radiofrequency ablation, we use thermal coagulation to cause necrosis in the lesion, and in osteoblastoma, there is a 90% success rate, and it is the primary option for treating this condition. Now this is a right hypochondrial X-ray, and you can see the contrast in the contrast which has been injected, and this question itself gives you a clue of what is the study, what is the type of biliary drainage, the type of biliary stent and the indications for stenting, what is the full form of PTBD, and what are the routes for biliary drainage. So now this is a percutaneous, this is a catheter which has gone in through the left left biliary duct, and it's gone through a stricture and it has entered the duodenum, and we've injected contrast, and you can see that the duodenum is filled with contrast. So this is a percutaneous transhepatic biliary drainage. Now, what are the types of biliary drainage? It can be either external or internal external. If you are not able to cross the stricture and you leave the pigtail just to drain the intrahepatic biliary ducts, it is called an external type. In this patient, the drainage catheter has reached the duodenum, so it is internal and external, meaning that there are holes in this catheter from here up to the level of the obstruction. So bile will drain via these holes into the catheter and into the normal duodenum, so facilitating digestion. So that is internal drainage, and also this bile can also drain externally to a bag which you, a uro bag which you have attached. So there is both internal and external drainage which is possible in biliary. That is why it is called an internal external drainage of the biliary tree. So what are the types of biliary stent? You can have a plastic or a metallic stent. The plastic stent is used for benign strictures because it will be removed after the period when it is necessary for drainage, while a metallic stent is placed in malignant strictures. It cannot be removed and it is a permanent thing. But usually the biliary patients with biliary carcinoma, their lifespan is quite less, so we can put a metallic stent for them. Now PTBD means percutaneous transhepatic biliary drainage, which means we go through the liver, through the skin, liver, and we reach the dilated biliary duct under ultrasound guidance before passing the guide wire and the catheter is placed in situ. Now you can also do the biliary drainage via endoscopy and percutaneous transhepatic. Endoscopists can also place a stent in the CBD. This is a image of a contrast image of a 65-year-old female with cancer cervix and bilateral hydronephrosis. So what is the procedure shown? What is the preferred position of the patient for this procedure, and what is Brodel's line, and what other interventions are possible through this method? So now you can see that these are both renal calyces. They are grossly dilated bilaterally. In the right side you can see the ureter, and you can see two catheters placed in bilaterally through the percutaneous route in both pelvis system. So now what is the procedure shown? It is a percutaneous nephrostomy. What is the preferred position of the patient for the procedure? We usually put them in the prone because the kidney is posterior and the approach is posterior lateral rather than direct in subcostal anterior into the kidney. And what is the Brodel's line? It is an avascular zone in the posterior lateral aspect of the kidney through which we prefer to place the catheter to prevent hematoma or injury to the vessels. So that is why we take a posterior lateral approach with the patient in a prone, and we try to approach, it is just an imaginary zone, you cannot see it, but we try to get into the posterior calyx rather than the anterior calyx for drainage. And you can, once you have got a catheter inside, you can do lithotripsy or DJ stenting. Lithotripsy is breaking up of the calculi, which is done by the urologist, or you can do a DJ stenting. Here you can see a DJ stent which has been placed in the dilated pelvic calyces system, passes through the ureter into the bladder. So in this case you can remove, once you've got the axis and place the DJ stent, you can remove the external drainage. So this is much more comfortable to the patient because it is, the urine is draining internally and he doesn't have a urobag outside. Now this is, what is the technique which is commonly used for vascular access? Which artery is commonly selected for access for any vascular interventions? What is the use of the vascular sheath that we put in after vascular access? And what are the two common complications of this puncture? So the technique is obvious, all of you will probably know it. It's called the Seldinger technique. And which artery is commonly used? It is the right common femoral artery. So you should not puncture the right SFA. that is the superficial femoral artery, or nor should you go high into the external iliac artery, because both will lead to complications. If you have punctured the external iliac artery, it can bleed into the pelvis and you will not be aware, because there will be no hematoma forming in the groin, it will be bleeding internally. So you should be careful you do not go too high. If you go too low below the profunda, then that also leads to complications when you go into the superficial femoral artery. So the correct artery is the preferred artery is the common femoral artery. So what do you do if the common femoral artery is blocked or they put a graft? There are other routes of access like the brachial or the radial. And the radial is now the preferred one, because the patient can walk the minute this procedure is over with just a bandage in the arm, and that is a normal route used by cardiologists. But radiologists, we are still more comfortable with the radial technique, and because the catheters are also shorter to come from, we are comfortable with the femoral technique, because the radial artery technique leads longer catheters and thinner catheters. Now the two common complications of this puncture is groin hematoma and pseudoaneurysm of the common femoral artery. So I think you will all know what is a Seldinger technique. We first put in a needle into the femoral artery, and once the blood is, you confirm that the blood is spurting, you can insert the guide wire, hold the guide wire, remove the needle, and over the guide wire you can put the vascular sheath, and then make sure that the sheath is having blood. Okay. So what is the, I think we did not see, what is the use of the vascular sheath? So once you put in this sheath, this is a vascular sheath, and this is a 6F, it is color coded, 6 or green is 6 or orange is 7F and all that, you have color codes. So once you put the sheath, you can have any number of wire exchanges or catheter exchanges into the femoral artery. So that is the use of the vascular sheath. And the common complications, as I said, aneurysm. Now what is shown in this picture and what preparation is shown, what is the use of this material that we have prepared, what type of agent is it, and if you want to ensure decreased operative blood loss, when should this procedure be done? How many days prior to the operation should you do the procedure? So what preparation is shown in this picture? It is a gel foam slurry. And what is its interventional use? It is used for embolization of vessels. Either it could be for tumor or for preoperative embolization, or sometimes even we don't use it for aneurysms here evermore, but you can use it in fibroid tumor embolizations. And it is a temporary embolizing agent. After about 72 hours, there may be partial recanalization of the artery which we have occluded, and we usually do this procedure 48 hours prior to surgery to decrease the operative blood loss. So the surgery should be done within 48 hours or 24 to 48 hours, because if you do it a week later, it could recanalize and there could be blood loss again. So what are the other embolizing agents? You have PVA, which is polyvinyl alcohol. They come in various sizes, 200 to 2000 microns. Commonly used is 300 to 500 microns. The other embolic agents are glue, which is used by endoscopists usually for varices, but we can also use it. Onyx and squid are very expensive. They are already opaque because of tantalum, and they are less they cause less complications, very costly, and so they are mainly used for intracranial use where we do not want any complications, and the other metallic coils can also be used as an embolizing agent. This is a male 38 years old with severe abdominal pain and hematemesis. The CT is given, which is obvious, the diagnosis is obvious. What is the diagnosis? Which artery is involved? On endoscopy, what finding will you expect in this patient, and what is that finding called, and what is the management you would like to do? So what is the diagnosis? The patient has chronic pancreatitis. You can see the calcification, and you can see the peripancreatic fat infiltration. So it is acute and chronic pancreatitis with a pseudoaneurysm in the wall of the pseudocyst. So you can see a pseudocyst and the contrast enhancing aneurysm in the wall of the pseudocyst. So it is equal in density to the aorta, so it is a pseudoaneurysm in the wall of the pseudocyst. Which artery? It is arising from the gastroduodenal. This is the celiac, this is the common hepatic, this is the gastroduodenal which comes down, and the rest continues as a proper hepatic, and the aneurysm is seen arising from the gastroduodenal. So this is a gastroduodenal artery aneurysm. And on endoscopy, what would you find? You would find that there is bleeding from the pancreatic duct, and that is called hemosuccus pancreaticus. And what is the management? It is coiling of the aneurysm, or you can place a stent graft. You can place a covered stent over the neck of the aneurysm. Both can be done. So this is the patient with the aneurysm. This is the catheter in the hepatic artery. You can see the gastroduodenal artery and the proper hepatic artery. This is the faint filling of the aneurysm, and the coil has been done, and this is the post procedure where you can see the thrombosis of the aneurysm. Now this infant is present with a painless neck swelling. This is the MRI, probably it's not very clear, but what you can see is a large hyperintense lesion. So describe the findings, what additional sequence will help you in the diagnosis, what is a non-surgical management which is possible, and what is the criteria for antenatal diagnosis. So the findings is it's a T2 hyperintense septated macrocystic mass which is arising from the lateral aspect of the neck and pharynx, and it is not communicating with the CSF in the spinal canal. And dynamic contrast, if you think it is an AV malformation, to decide whether it's a high or a low flow malformation, you need a dynamic contrast study which could either be in MR or CT. And the non-surgical management is percutaneous sclerotherapy of under ultrasound guidance you can do. Of course, not for such large lesions, but other low AV malformations we can do a percutaneous sclerotherapy. And in antenatal period, you should look for the nuchal thickness or the septated cyst in the antenatal period during the 11 to 13 weeks scan. So what's a low flow vascular malformation? It could be lymphatic or venous. It could be macrocystic or microcystic. There will be no phlebolytics. There will be large cyst in the macrocystic type. There will be no flow or only peripheral flow, and it will have a fluid intensity in all the sequences on MRI. There will be no flow void, suggesting that it is a low flow malformation, and there will be no enhancement with contrast. This is a 42-year-old male with repeated episodes of hematemesis which has not been controlled by endoscopic methods. So what you see, 2 CTs have been given, the axial CT at the level of the liver and the coronal CT. So what is the diagnosis? What is the classification of the findings that you've noticed, and what is the draining vein, and how will you manage this patient? So it is obvious, you can see this is the stomach where there are hyperenhancing tubular lesions in the gastric mucosa and in the gastric mural, and in the coronal section you can see the enhancing tubular lesions which is draining downwards. So what is the diagnosis? It is gastric varices. And what is the classification? I'll just come to it. The gastric varices are classified into isolated gastric varices and gastroesophageal varices. And where is it draining? It is draining into, it commonly drains into the, comes inferiorly and drains into the left renal vein, which drains into the IVC. So this is sort of a portosystemic connection. And what is the interventional management? It is called BRTO, is the older technique, which means balloon occluded retrograde transvenous obliteration. This is the BRTO, but nowadays it is replaced by CARTO and PARTO. PARTO means plug assisted retrograde transvenous obliteration, and CARTO means coil assisted retrograde transvenous obliteration. So what is the meaning of this plug or BARTO, or what is it? It means that we enter the renal vein, and from the renal vein we are cannulating this varix and this vein, and then we occlude this main vein and then inject the sclerosant or the occluding agent above this vein. If you do not occlude this and just inject it, you cannot, even if you go up till the level of the gastric varices. So this is the draining vein, and this is the actual varices, gastric varices under the submucosa. So even if your catheter goes here and you inject the sclerosant or occluding agent, because of the fast flow, it will all drain back into the renal vein, IVC, and will reach the lungs. So we have to occlude the draining vein before injecting the sclerotherapeutic agent, and that is why the occlusion can be either by balloon, coils, or the plug. So this is the plug, which is called the Amplax plug, and you can see it on the X-ray, this disc and the inner balloon shaped. So this is partially occluding the vein, and then you pass your catheter up and do the inject whatever you want, the sclerotherapeutic agent. So now the Seren's classification of gastric varices, this is the gastroesophageal varices type 1, which is on the right side. The gastroesophageal varices, which goes on into the fundus of the stomach also. This is the isolated gastric varices type 1, and more in the body is called the type 2. So this is a gastric varices on CT, and this is a diagrammatic representation where you come from, there's another question I think. No, the draining vein. Okay, fine. So you come from the vein and femoral vein into the renal vein and occlude it and then inject into the gastric varices. So what is, this is a CT scan of 40-year-old male, and you can see this is serial sections are given, and what is the diagnosis, which is obvious, what is the diagnostic sign on MRI, what is the interventional management for this patient, and what is name any associated syndrome. So the diagnosis is obvious, the peripheral nodular enhancement, which delayed filling up from peripheral to center. So it is a giant hemangioma of the liver, and on MRI you get a light bulb sign on T2 weighted image. There are many techniques for the interventional management. You can do angioembolization of the feeder artery, you can do percutaneous sclerotherapy or RFA for these lesions. But these are done only for symptomatic lesions, and just incidental hemangiomas need not be treated. The syndromes associated are Kasabach-Merritt, where there is decreased platelet count and leading to bleeding, or the phases association, not with liver hemangioma, but hemangiomas elsewhere in the body, especially the face, where you get posterior fossa anomalies, hemangiomas, arterial anomalies, cardiac and cerebrovascular anomalies, along with eye anomalies, sternal defects, and supraumbilical defects. This is a patient, 38-year-old female who presented with hemoptysis. So this is a study which has been done, and this is the angio. You can see the flow. Okay, and this is the still image. You can see where we are. So what is the study which has been done? What is the diagnosis? What is the route of entry for this study? What syndrome is associated with this finding? The percentage of people with this syndrome who have this or this finding, associated finding, and what is the mode of inheritance, and what are the complications associated with this finding. Okay, so this is a pulmonary angiogram, and what is the diagnosis? It's a pulmonary AV malformation. There are two malformations which are seen. There are two aneurysms and fistula formation, one smaller and one larger. And what is the route of entry for the study? The catheter has to come into the pulmonary artery. So where is the route? It is from the femoral vein. Femoral vein, IVC, right atrium, pulmonary artery, and main pulmonary artery, and then you can go selectively. So the route is not through the femoral artery, is through the femoral vein. And what is the syndrome associated? This is the Osler-Weber-Rendu syndrome, or the hereditary hemorrhagic telangiectasia. And 15 to 33% of people with Rendu-Osler can have a pulmonary AV malformation, and it is inherited in an autosomal dominant fashion. So what is the complications of this finding? You can have a paradoxical embolus which will lead to abscess and stroke formation. So paradoxical embolus because there is no filtration by the lung, and whatever enters the pulmonary artery will go directly into the systemic circulation. So there is the microbes are not filtered by the lung, and therefore you can get anywhere, you can get abscesses or you can have embolism to the brain causing stroke. So there are a lot of complications because of this. So this is the post procedure. You can see both the coils in the plain x-ray, and this is the post procedure angio where you can see now that the AV malformation is not filling up. This is a patient with hepatocellular carcinoma in the right lobe of liver. Now, what is FLR? How is it calculated? What procedure is required to improve this patient outcome if the FLR is low? And post procedure, when would you do the surgery? So any idea what FLR is? Yeah. So this is FLR means the future liver remnant, and it means it is the total liver volume minus tumor volume minus resected volume minus tumor resected. That means it basically means the functional liver volume, that is the whole liver minus the tumor. So the functional liver volume minus what you have resected, the functional liver you have resected, and by the functional total functional liver volume. The functional volume means you are minusing the volume caused by the tumor, because that is not going to help in liver function. So this FLR, future liver remnant, should be at least 20% if the patient is having a normal liver functions, and in cirrhotic patients it should be 40. So if it is less, that means if this patient, the left lobe, they will do a extended hepatectomy where they may take off the fourth segment also. So the clinician surgical will tell you, I'm going to do an extended hepatectomy, please calculate the FLR. So you leave out the segment 4, calculate only segment 2, 3, and you find out the percentage. So if it is less than 40% in a normal patient, or 40% in a cirrhotic, or 20 in a normal patient, normal liver function, then they will refer for portal vein embolization. So we will embolize the segment or the portal vein which is supplying the tumor, so that there is preferential flow of the blood into the left lobe or the normal segment, normal lobe of the liver, so that it begins to hypertrophy before they go in for the extended hepatectomy. So if the FLR is low, they will refer for a portal vein embolization. And post procedure, when is surgery recommended? Usually the hypertrophy is maximum between 3 to 6 weeks. So in the around the 5 to 6 weeks you can do the surgery. So this is the catheter in the portal vein, and this is the diagnostic portal vein. So you can, again you have to come back and embolize only this segment, and being very careful to preserve the left lobe. This is a 64-year-old male with a right hepatic resection for hepatocellular carcinoma. Now the follow-up triple phase CT shows image is given. What are the findings on CT scan? What is the possible differentials? What would you recommend for this patient? The maximum number of lesions that can be treated non-surgically by the IR, and underlying pathophysiology of the recommended treatment. So what is the findings on CT scan, the differentials, how would you manage, and depending on the number of lesions, how would you manage, and what is the pathophysiology. So you can see there are 2 enhancing nodules in the remnant liver, and so there are 2 hyperenhancing nodules which are less than 3 centimeters in size. The differentials would include regenerating nodules, hemangioma, or hypervascular mets. Now, so what is the method of treatment? You cannot go again and do surgery because he's already had a right hepatectomy. So the ideal would be a RFA. This is the post RFA where, and you can see that there is no enhancement. This lesion did not show a typical feature of HCC, so it was left alone for follow-up. And so this is a radiofrequency ablation. You can do RFA with a curative intent for 3 nodules less than 3 centimeter in size. More than that or larger, then you cannot take it as a curative treatment. So this, the physiology of RFA is as the tissue temperature increases to the range of 60 to 100 degrees centigrade, coagulation necrosis of the cells occur, and that is why we use the RFA. A 35-year-old female with menorrhagia, this is the ultrasound pelvis sagittal view, this is the uterus. So what can you see? You can see something echogenic here. So what are the options for managing this patient? Prior to interventional management of this patient, what history is very important, and will you do bilateral or unilateral procedure, and what is the particle size recommended and why? So the options for managing this patient are myomectomy, hysterectomy, or uterine artery embolization. So when you do, before you go in for a uterine artery embolization, because the particles can also occlude the ovarian artery and patient can become infertile post procedure, we have to ask whether she has had children and is her family open. So if she's planning to have children, then this procedure is not recommended. And you also should do a pap smear to rule out any underlying CA cervix or uterine cancer before you go in for the treatment. And always it is done bilaterally, both uterine arteries are embolized, and usually we use 350 to 500 microns or PVA to prevent shunting into the pulmonary artery. So here is the catheter placed in the left uterine artery, and the filling of the vessels are seen. A 52-year-old male with severe abdominal pain and falling hemoglobin levels. What does the CT scan show? How would you manage this patient, and is biopsy necessary before management? What drugs are used in the procedure? What is the name of the procedure, and what is BCLC? So this is obvious, it's a liver tumor which has ruptured and it is leaning to hemoperitoneum. So the CT scan shows a ruptured liver tumor with hemoperitoneum. It is a hepatocellular carcinoma. So how do you manage? We would like to do a transarterial embolization, because with such bleeding it is very difficult to take for immediate surgery. Is biopsy necessary before management? Now you are going to put a chemotherapeutic drug into the vessel of this patient. How do you know it is cancer without knowing it's cancer? Suppose it is just a hepatic adenoma or some other benign tumor, you cannot put a chemotherapeutic drug. So is biopsy necessary before managing this patient? No, because triple phase CT MRI showing the typical features of HCC is more than enough for diagnosis HCC. You don't need a biopsy before treatment. And what is the procedure? This is called TACE, transarterial chemoembolization, where doxorubicin is put. Lipidol is a oily contrast media which retains the drug inside the tumor. So this is the contrast media you can see post embolization, and you use gel foam to occlude, or the PVA to occlude the feeding artery. This is the selective catheterization of the artery, and you can see the hypervascular tumor being embolized. Now what is BCLC? It is a Barcelona clinic liver cancer. So this is one of the strategies to manage liver cancer, HCC, and it is divided into stage A0, stage A to C, and stage D. So stage 0 is a very early stage where you can just manage the patient. Stage A is by surgery, which is curative, or liver transplantation, but we are more concerned with the intermediate stage where the TACE is indicated. Okay, and RFA comes under the curative. As I told you, 3 nodules less than 3 centimeters can be done. So this BCLC helps in the management or the management of HCC, whether it is curative or whether it is palliative treatment. So once it is stage D, so it depends upon the child Puke scoring and the performance status of the patient. This is a 45-year-old male, the X-ray, contrast X-ray given, and he is a cirrhotic. He's got medically resistant ascites. So what is this procedure which has been done? What are the other indications for this procedure? What score is measured to predict the prognosis before doing this procedure? What is the dreaded complication post-procedure? So I think you will all know this is the tips The catheter is in the portal vein, you have injected, and from the portal vein through the shunt or the stent created, it is going into the IVC into the right atrium. So what is the procedure shown? It is called TIPS, transjugular intrahepatic portosystemic shunt. Transjugular means the route is via the jugular vein and into the IVC, right atrium, SVC, right atrium, IVC, and into the hepatic veins. And from the hepatic vein, we are placing a shunt through the liver parenchyma into the portal vein. Now what is this shunt? This shunt is composed of two portions. One is covered and with a polyethylene graft, and one portion of the stent is uncovered. Now why this is? Because this covered stent should be in the parenchyma, the covered portion, and the uncovered portion is inside the portal vein to allow blood flow into the both branches of the portal vein. And this covered stent is to prevent leak of blood into the parenchyma. So we are placing it from the right hepatic vein to the portal vein. Usually one branch, usually the right branch of the portal vein, a stent is placed. So what are the indications? It is done in morbid ascites, varices, or Budd-Chiari. These are all only if medical management is not possible, only then we do it. It is not done as a initial method of treatment. So what score we measure? We measure the MELD score, which is the model for end stage liver disease. Anything above 16 is a bad prognosis for the TIPS procedure. And the dreaded complication is hepatic encephalopathy, because the portal vein blood from all the intestine directly reaches the brain, and so you can have hepatic encephalopathy. Just two more, I'll go fast. So this is the vascular shunt. You can see it in the a plain X-ray. So this is an image showing a renal artery stenosis. What is the etiology? What is the name of the catheter which you see here? How do you manage, and what are the types of stents? So here they put the stent and restore the renal artery. It is a left renal artery stenosis. It can be due to atherosclerosis or fibromuscular dysplasia. The catheter here is a pigtail. Notice the curve of the catheter. You can do an angioplasty or stenting, and you have self-expandable stents or a balloon expandable stents can be used. And this is a covered stent can also be used, which is called stent graft. What is this? What is this device? What is the indication? Where do you place it? Is it temporary or permanent? And what is the complication of this device? So it is a filter, IVC filter. It is placed in DVT patients to prevent embolism from the DVT to reach the pulmonary circulation. It is placed in the infrarenal IVC. It is usually temporary and removed in 6 weeks to 6 months time, and sometimes there are permanent filters now arising. The complication, sometimes it can penetrate the IVC wall because you see there are hooks here, and then removal endoscope via the interventional procedure it will may be a bit difficult. Now just a last one. What is this study here? Which artery is blocked? Options to manage this patient. What is the interventional management you can do based on which study will you choose whether to do intervention or not, and what is the golden period. So here you can see this is a cerebral angiogram. The catheter is in the right ICA. You can see the intracerebral ICA, the bifurcation into the anterior cerebral, middle cerebral, which is occluded, and after the clot is removed, you can see restoration of blood flow in the MCA. So this is a cerebral DSA, middle cerebral artery clot is seen. You can do a thrombolysis of the clot, or you can do a mechanical thrombectomy. The CT MRI perfusion study will only show which is the penumbra, and only if it is present when you can do a thrombolysis or a mechanical thrombectomy. And within 4 to 5 hours to 6 hours from the start of stroke is the golden period when you can treat these patients. So the thrombolytic agents can be delivered intra-arterially by placing a catheter. It could be streptokinase, urokinase, or usually nowadays it is tissue plasminogen activator. And it is used in hyperacute stroke. You can also do a mechanical thrombectomy where the catheter is gone into the thrombus and a rotor is thing, and the thrombus is aspirated and brought out, and you can restore the blood flow. So this is just a brief look at interventional procedures. So with minimum access we can provide maximum result to the patient. Thank you.